and they've raised €5,000 that they're going to donate to Net Patient Network. We have a lot of plans to do things, which does obviously take funds, so it's wonderful to receive that. Sad in the circumstances. So can I ask Pauline and her sisters to come up and we make a presentation? Andrea here? Andrea? No. Another family, Flannery, Margaret Flannery, and her father, Owen, have again done fundraising for Owen's wife and Margaret's mother, who passed away last year, I think. But they've raised, I think it's 10,300, which is a huge amount of money. So if we can ask Margaret and her dad to come up, and we'll just take a few photos, please. Margaret? Ah. Oh, here she comes.
Everybody, my name is Andrea, and Mark and I are the co-treasurers of Net Patient Network. It's fantastic to see everybody here today, and the raising funds is more and more important. We have received money from pharma companies to support the patient day and everything in the past, but the way the organisation is growing, these contributions to the OD family and Margaret's family, they will make a real difference to having events like these and other support services, which we're gradually developing as pilot projects on the committee for to support fellow NET patients. So we'll just simply say thank you very, very much for your efforts, and I hope you will feel that it's a way of keeping the memory of your loved ones alive. Thank you very, very much.
So on that topic, we have a committee, but we really need new blood. We need people that are willing and able to take on projects and do them. We're all volunteers. Nobody gets paid anything. But we really need some people to come on board with us. So I'm putting out a call there. If you are interested, if you feel you're willing, but you know, we're looking for people that can do things, get something done. So if you are interested, please approach me or approach any of the committee members. Give us your details, and we'll be back in touch with you. But we'd love some more people to come on board. As Andrea said, there's projects there that we want to do. They do take money, but more importantly, they take commitment, they take energy and time, and we don't all have that. So, but we need people to come on board and do that with us. And there's some active projects we'd like to do in terms of awareness, in terms of working with the Irish Cancer Society to get more knowledge about NETs. There is a GP awareness program that Inca have developed, which we want to push out there, and we're actually on that. We will have information on the Net Patient Network website, which is netcancer.ie. On that will be flyers that you can download and print, a letter that you can download and print, And we'd encourage you all to bring these leaflets to your GP practice and inform them that there is a training program online available. It's free. And those who partake in that can get continuing medical education points. So the idea is to raise awareness amongst NETs, amongst the primary care physicians, so that hopefully if they see somebody in the future, that they may just put that question mark in the referral letter to whether it be an endocrinologist, a gastroenterologist, whatever, and question mark NET. I mean, and if we can get that information out there, it'd be really helpful. So please download that. It'll be on our website. We'll send it out in our newsletter. We send it out by on Facebook and on our website. But approach your GPs. And what we were doing then from a higher level is we're trying to work down from the top down through the Association of GPs to raise awareness of this program. The important thing, or the grab for the GPs, is that they get CME points. It's 1 hour that they need to watch and then answer a few questions. But it's good. And Dermot O'Toole was one of the primary providers to that program. It's gone out across the world. It's in multiple languages. And it was launched officially on Net Cancer Day, which was November 10th. But we need to do that in Ireland and try and get that message out there. So there's other projects that we want to do, but we need people. So if you have time and you have the energy, put yourself forward, please. And we actually had a volunteer for a new treasurer role with us last night, so that's going to be great. And Andrea and I can do other things. We actually have the video working now, so I think we're going to play that. I know you're all sitting here, and thank you, but...
I'd like to use this journey as my chance to leave something better in place for those who come after us. And I'd also like to let those who love me see that, I rose to the challenge as best I could.
I want to say to people who are living in Ireland, who are citizens of the European Union, look, this is what's out there, and this is what you can access, not on a grace and favour basis, but by right.
Don't for a second give up. Like PRRT has come, the Centre of Excellence has come, treatment abroad has come. Ireland really is a better place on many levels. The health service is one of them. Cancer, NETs included, is still killing people, but thanks to the Centre of Excellence model, many fortunate ones like me are managing to live with the disease. During 27 years, ducking and diving, I've seen the building of what is an Irish version of the Swedish model for patients like me. It is a work in progress. But if I ended a programme 20 years ago saying I'm grateful to be a European, I sign off on this one saying I'm proud to be Irish.
So it's very hard to look, but we miss him a lot. And, it's on us to continue the journey that he started out on, to continue in the way that he did it, which was with dignity, honour, respect, and in cooperation. We need to work with all of our partners, the medics, the HSE, pharma companies, and it's about working together in partnership. And that was Tommie's great message to us all. And he got us to where we are now, and we need to continue. So, move away to question and answer session. If we can invite everybody back onto the stage, we'll do that. We need to have a few words quickly from Mary. So as people are getting in place, Mary's going to give us a little bit of a quick update on social media channels.
Good morning. Myself and my husband Owen would like you all to say how grateful and thankful we are today for attending the Net Patient Day. We both run the Facebook groups called Neuroendocrine Cancer Ireland Support. Our main Facebook group is for everyone, patients and their carers and families. Our patients only group is a support group just for patients, because what I found is that if you have a husband or a wife or a daughter or a son, you mightn't like them to know, look, I'm in difficulty, I don't want to upset my husband, my partner, talk about this. So what I done then is I set up a patient-only group. So both groups have increased in numbers again this past year. We have 509 members. 500 of them are Irish patients or family members who joined on behalf of a patient who was not on Facebook. This is in our main group. And then we have 236 in the patient-only group. So some patients join the main group and the patient-only one so they can keep in contact with everybody. While it's not nice to see more patients being diagnosed with neuroendocrine cancer, at least more patients who are being diagnosed are finding our support groups. We are thrilled to see both groups are successful and patient and family members are answering posts and commenting and offering support, help, advice and friendship. This is what happens in our group. They should be called a support each other groups. We are aware that many patients here are not on Facebook groups. We would love if you could all join. I would especially love if you're a patient, you could join the patient-only group as well, because we do talk about more personal things in that group. There is no requirement to participate, but you will know that the option is there if you need it. We also have lots of net-related information, especially for patients, especially for newly diagnosed patients and anyone who is heading to Sweden for treatment. We have files and the groups as well. If you're interested in joining, go to Net Patient Network website and look at the top menu, look for patient supports. When you put your cursor on the words, a drop-down list will appear. Click on Facebook support groups. You can also contact myself and Owen or Facebook, or go to the Net Patient Network website and send an email from there, and it will be forwarded on to us then. We had some regional net chatter get-togethers over the past year, but we need more people to join net chatter get-togethers. This is where we, as groups, we meet and have a coffee and have a chat and see how each other is doing. So what we need, we had some in Cork, we had some in Kerry, but we actually need, if you're living in Kerry, as a patient, you say, I'm a patient diagnosed for a few years. Look, I'll get together with newly diagnosed patients, we'll have a coffee, we'll have a chat. So if you're in Kerry, Limerick, wherever you are, because we're at the moment it's just running Cork and Dublin, so we need patients to stand up and volunteer to have their own get together and have coffees and with other patients in the area. So it normally happens sometimes every 6 weeks, every 12 weeks. It's just for 2 hours, just for patients to get there together and help each other. We normally have ours in the local hotel lobby, but it can be a cafe or anything like that. And Next Patient Network are going to sponsor a coffee and a scone, so that will be a new thing this year that we're going to try and organise. We also need patients to volunteer to be a buddy to the newly diagnosed patients. This is what I talked about last year, and we had a few people who stepped up to be a buddy. But now with 500 and odd people and 267 patients in the patient-only group, we need more people to step up and be a buddy to somebody who's newly diagnosed. And all it means is that they send you a message, look, I'm feeling nervous, I feel alone, I need somebody just to talk to, and you just support that person, even if it's 20 minutes just to reach out. So if anybody is interested in being a buddy, you can contact myself and Oren on the Facebook site, or you can send the email to the info@nepatientnetwork.ie, and they will also get through to us. We like to help everyone who volunteered to help out at last night's dinner and today's events. We had people to help out, showing people where to go and counting numbers and everything. That this is all how we all work together for this event. We'd also like all the doctors for everything that they do for us patients. It's great to see them again this year. Every year we are amazed that they give up their time to come to our event and all they can do on the day to help patients. We also like to thank the Irish Cancer Society for attending our event. And then all of us patients and patients' family members are deeply saddened by the loss of our friend Tommie. Tommie meant so much to me and to many other patients and family members and his fellow committee members. He was so proud of Net Patient Network and was happy to see us patients helping each other patients and being there for each other. This is why we need to continue Tommie's outstanding work and continue to improve things for all neuroendocrine cancer patients and their family members. And finally, what I like to do is also, we have a charity and we need to get more funds in. So if you are doing a mini marathon or whatever you're doing, if you can think of us, it would be greatly appreciated. Thanks.
So we finally get to the Q&A. So any questions from the audience first off? Let's get started.
Mark, I got a couple of questions last night, so I might start with one or two and get warmed up. One question was about massage, and is it safe for neuroendocrine tumour patients to have a massage, or does it depend on what treatments you're on? If anyone would be able to advise that. There's mixed messages on social media and...
So it's absolutely fine to have a massage. There is an interesting phenomenon with people who have, say, carcinoid in their liver, that palpating or pressing on the liver can cause a little bit of a flush. So you might just, maybe if you had that, avoid that area in the massage. I've never had a massage, actually, so I don't know if they massage. I don't know if they massage the liver, but that would be the area to avoid. But it's absolutely safe, and massages are apparently good for you.
We know what to get for Christmas.
That's a major revelation there. Just one little comment, just why there might be mixed messages. Sometimes when people are on chemotherapy, their platelet count can be low, and your platelets allow your blood to clot. So if someone's platelets were in a kind of dangerously low level and they were getting a very deep or hard massage, maybe they get some bruises or something like that. But I totally agree, for the most part it's safe, but that might be maybe some of the reasons why there are mixed messages from that perspective.
Okay, another question, and I know it was through the presentations this morning it was talked about, but I suppose some of the concerns, and it's been on the Facebook page as well, for some patients when they are brought to clinic, that maybe the MDT hasn't happened, or that they don't get the information they need when they visit. And I suppose it's about that question about what can we put in place, that maybe that there be a postponement, or do you know that you don't arrive and then that it's not really great for the doctor or for the patient, that we can progress with the next steps.
Yeah, hi. So I'll answer that, I think. First of all, I always try and say when patients come to the clinic that that this pathway, so your scan, your bloods, the MDT, and your clinic appointment, that's the ideal pathway and outcome. And unfortunately, it doesn't always happen that way. So I suppose the older patients, as in our, I don't mean age-wise, would know that, say, if their scan hasn't happened or something like that they'd get in contact and say, look, my clinic appointment is in, February, but my scan is until March. So, rearrange it. And I always try and say, keep your scan appointment and we can change your clinic appointment. It's very, very flexible. I suppose sometimes we put people on the MDT and for whatever reason, we have to rediscuss them. Maybe their scan didn't come from Cork or wherever, Letterkenny. There's often things that can happen out of our control. So I suppose as a team, we do our best for that to happen. Sometimes, unfortunately, it doesn't. So I don't know if you want to add something.
It is a real problem. So even at yesterday's clinic, there was 2 people. One had not had the scan, and one had had the scan, but because of shortage in radiology at the moment, it wasn't finally reported. So we looked at it, and so it's a practical issue. We are continuing to try and do our best. Once you know the sequence, so like if you have your scan this week and your appointment's on Friday, like make an effort to bump it forward a couple of weeks, because it takes that kind of length of time for the scan to come before the MDT, etc. So it's working together to make it better.
And also just Hussein had showed on a slide there, which was kind of interesting, that 2018 there was 500 plus patients going through the MDT. Now there's almost 1,000. So I suppose we probably need more resources also, to make everything a little more efficient too.
I think we as a patient group should probably push the message out there to patients that this is the expected sequence, and if you find that you're getting your appointment before the scan, then get in touch with whoever the contact point is. So we should push that message through Facebook and through our website and so forth. Question here.
Sorry, just in relation to what we're after been discussing there, and I know you said, like, look at your scan date and then look at your appointment date, but how many weeks are we talking about? Should we be allowing 4 weeks? And then you also spoke about blood test. Are we expected to have a blood test in between that, or is that individual patients?
Yeah, normally when you come to the clinic, you should be leaving the clinic with blood forms for your next scan appointment. So when you come in for the scan, like for people who are in Dublin, they can pop in anytime, but obviously people from outside Dublin, it's handy to get your bloods done the same day as a scan. I would say to patients up to 6 weeks to be realistic, because you have to wait for the blood result to be back, and just to make sure there's no hiccups along the way with the scan, to be radiologist, whatever the MDT. So I would say 6 weeks is probably obviously we'd love it a bit earlier, and it does happen earlier, but I think that's a fair time scale, really.
Yeah, okay, thank you.
Maybe, Lisa, we can work with you and put something up on our website as to this is the typical kind of sequence and what people should watch out for and when they should contact you or whoever it may be to change things. Questions?
My observation, first of all, I just miss my friend. He was very close to me, more so maybe than the family. There are a lot we go in common, but that's life. We all have to go through that, so we have to accept that. About the MDT, which has become the MDM, I just noted that St. Vincent and Galway, Cork, are having the MDT over the satellite. Can't this also include the Mater, Beaumont, Tala, and St. James? Because I'm just talking way back in the 80s when we were having the health boards, which each health board is doing whatever they are doing. And we are trying to streamline, even when Prof. O'Shea, Prof. O'Toole, and Professor, whoever will come after them, that we have a center such that it is known worldwide going forward. Like we know Beaumont is known in Ireland of Ireland for the brain, nowhere else. So can the experts whom we are having here, knowing that we have come a long way, as Prof. O'Shea will attest to that, in that we started this thing with a very few people from UK when they came to Radisson Hotel at the back of UCD. Now look at us here, and we are just talking this. So if we can bring that, because the HEC has got a policy, if you live out in Skerries, for example, or Santry for my case, you are not going to be taken on the back of ambulance to St. Vincent. You are going to be taken on the back of an ambulance to Beaumont. And if the Beaumont are not aware of what St. Vincent is doing, you are done. So that is one thing. The second thing is the disease has got no boundary. And as a result, our net patient going forward, you should think, if this is going to be a charity with a force to be reckoned with, also thinking of the children of the loved ones who we are going to leave behind in case they are on education, so that we can caution them, rather than us saying, we need funding, we need funding. We have those drug companies. If we ask them nicely, they can also chip in. Because I'm just saying that it will happen to one of us along the way. So those ones are my observation going forward. So that's it.
All right, Charles. Does anyone want to comment?
Can you take the microphone away from that gentleman? And don't give it back to him? So thank you for that, Charles. We have hospitals dial into our MDT from Tala, Beaumont. We need more awareness. We need continued awareness, and that GP module that gives CPD to educate primary care docs. I need to look at that. I haven't looked at it, but I need to see what the content is. So we need everything that you're saying there, more awareness, but the links between the hospitals and the health system in Ireland, as you know, has changed in the last month to this regional health areas. So there are 6 regional health areas. So we all have slightly different relationships than we had with other hospitals before. But as a national centre, it will remain that Galway, Cork, Dublin access for the 6, despite the fact that there's 6 RHAs.
Yeah, so I think going along with the first comment, IT is a huge deficiency at every aspect of healthcare. They're working on electronic patient record that kind of works through the whole system. There's a chemotherapy prescribing scenario now where I could see potentially what's being prescribed in Letterkenny. Vincent's and Galway are slight outliers in the radiology system. They don't talk, but they're coming online. So there is a lot of work coming to homogenize a lot of those things. But ultimately, I think the one thing that has really worked well is identifying Vincent's as the centre of NETs. And it's a very small community. You see the same faces up here every year. We all have each other's mobile phone, and I think it works so well for NETs. Everything here works so well for NETs. This is unlike we all treat other diseases and cancers. I mean, this is superb, highly educated patients, fantastic forum, small group of physicians, and we all talk. We're all friends. Just found out he hasn't had a massage. I know more about Donal. So I think it works tremendously well in NETs, maybe better than other things, that if we have a problem in Galway or Tipperary or Letterkenny, we know where to go to get that information. COVID has changed things. We can now do things virtually. You don't have to sit in front of Donal or Dermot or Mark or Hussein. That information can be got virtually. I think things are improving, and virtually has really helped, and we know where to go.
Sorry, my layman input as well, though, is that, Beaumont is never going to be the NET centre, nor the other hospitals. Vincent's is the NET centre with Cork and Galway. And they are building the expertise there across all the levels in that hospital. So that's where we want to have our cases seen. We want other doctors in other disease areas, other doctors, other consultants to know about NETs. And that's where we need to use our pushing for awareness. But we want everybody to go through Cork, Galway and Vincent's. That's what we want them to happen. Any more questions?
I would like to ask the doctors about, I have Carcinoid Syndrome, and it's normally controlled. And the problem is that if I run into difficulties, it's not just surgery I run into difficulty. I can also start to, the blood pressure starts raising, and I get severe flushing and very sick at home. Now, normally my husband can give me the rescue shots. It's the sandostatin, the 500 micrograms. But on 2 occasions, it's got so bad that I have been put into A&E. This year, I was put into A&E. Was actually, the blood pressure was so high that I was screaming with my head. And what happens is that when I go into A&E, I explain that we have the Carcinoid Syndrome. We bring the rescue shots with them. We try to explain. The thing is that I was 10 hours in A&E screaming with my head. They're trying to give me meds, and eventually it's my husband who had to get onto Derek Power, and he has had to sort out that I went into resus. So my question is there any way that we could do something that I'm afraid that the next time will be fatal if I go into bad Carcinoid Syndrome, I go into those symptoms. Is there anything that you could advise me that we can do? Is there any way that we could get the word out there that I need to be treated when it's this bad, or is there anything I can do? Thanks.
Okay, thanks. Thanks for the question. This is very important, and I think we've been working on the website last year, and we do have a PDF document now, and also we have the cards. If you could print these and to have these carcinoid cards in your wallets, etc. In cases of emergency, and sometime obviously we are happy to write letters. Like I have a lot of patients comes to me like going for dental procedures, etc. It is maybe very unlikely that without a major trigger, carcinoid could result in, in a major crisis without a major trigger. But I think it's good to carry cards, and it's good to have a website with a, with some reference there. Yeah.
Thank you. Again, I can understand and hear your fear. I suppose this is a rare condition. I think it's important to carry documentation, have documentation, because you're right, you know a lot more about carcinoid syndrome than a lot of people might do. I think, my patients might know that if they're very worried and anyway, they're more than welcome to, if they find themselves in an A&E and they're in trouble, they're more than welcome to ask for me. I can't be available at all times, but I certainly can be available on the phone. But one of the things it does, I think, and is that if you identify a doctor that's looking after you that knows what to do, automatically then the people who are actually looking after you realize this is unusual, this is different, this is something that we need to listen to the patient about. But again, I'd encourage you to do what you did and continue to try to educate the people, and if things fail, I would ask to have the person looking after you contacted.
My question is that I have had 3 sessions in Uppsala in the last 6 months, and I'm just back from my 3rd one, and the tiredness is shocking. Some days I just have to go back to bed. Is it normal or?
Tiredness is a very common side effect of PRRT, but if it's a bit unusual, you would need to look at other things just to make sure there's nothing else going on. I assume you are having your bloods. This is the first thing. There are other things, like this could be a heart issue, etc. So I'd encourage you to approach the consultant looking after you, just to make sure there is nothing else. But it is a well-recognized side effect of PRRT.
And the nursing point of view about that, if you have having some like tiredness or body weaknesses, just make sure that in the first week of after the PRRT treatment, you will develop that is more common. So that's why we ask you not to do any extraneous activities. Take it easy for the day, and then for a whole week, and then after that, a little bit of walking, a little bit of exercise, and proper deep breathing exercises can alleviate the pain and everything. And now, if you have any small abdominal pain and like that, you can take some paracetamols or any ibuprofen that is good. That is you're not allergic to, and then if worse comes to worse, like you develop really, really bad or any bleeding, just don't hesitate to go to the nearest casualty or the emergency department. They can sort you out there. Thank you.
Could we hear a little bit about the Carcinoid Syndrome as regards what are the most common symptoms of this? It's something that I have. I have no idea about it. I'm not in any treatment, and I wonder about going to the dentist, or if I were to have surgery or any of these things, what would I need to know?
I suppose there are various symptoms. Some people have carcinoid syndrome and have no symptoms at all. Some people have carcinoid syndrome and their biggest thing might be changes to their bowel or flushing. Some people have carcinoid syndrome and they have various, vitamin deficiencies and things that can be associated with it. Some people have issues with their heart. So I suppose it's important. It would be important to obviously be assessed. It will be important to have the testing done. I'm not sure where you're being looked after, but all again, once you develop a syndrome, once you develop something, it's so important that there's a team looking after you, that your case goes through an MDT process, with the experts locally and then nationally if appropriate. And there's a toolbox of treatments for NETs, for carcinoid, and it's important that you get access to that toolbox when the time is appropriate to be treated with items from that toolbox.
And it's so there's a reason we're all sitting here, right? So we love nets, right? You don't like nets but we like them, and we like them because they're unlike any other type of tumor, really. And a lot of people have, in inverted commas, carcinoid that is non-functional. They don't have any syndrome or any symptoms. And when the pathologist does a stain to see, to look at it under the microscope, it can be full of hormones, the tumor, but it's not pushing them out. And sometimes they'll do a stain on the tumor and they'll see no hormones, and the patient will have lots of symptoms, because what's happening is the tumor is making the hormone and pushing it out all the time. It's not staying in the cell. So they have lots of symptoms. So that's why I like to say it's one person at a time for this type of tumor. It really is the case. So there are some people have carcinoid without the syndrome. I can't remember how many are non-functional. It's like maybe 2/3, maybe 2/3. The majority are non-functional, and then others will start their monthly injection, and the flushing will disappear, and the diarrhea will go away. And I'm old enough to remember giving my first patient what was called octreotide. And it's the one that had to be given 3 times a day because the long-acting wasn't available. And this man had had diarrhea for ages and flushing for ages. And I gave him an injection in London and went back to him 3 hours later, and he was complaining of constipation. It was like magic. And he came back the following week, and he was a sign maker by profession, and he came back with Dr. Donal O'Shea's famous remedy for all things. So he thought I'd invented this thing. and I got this lovely sign, which I don't have anymore, unfortunately. So you've got, it's person by person. Not everyone is at risk of a carcinoid crisis, and the majority are non-functional.
And just one other thing is, we often follow people with blood tests and 24-hour urine collection to measure, you know, if you are having flushing or diarrhea, anything like that, just to keep an eye on that too. So hopefully, I'm sure you've had that done in whatever centre you're in as well.
Okay, I have a question from a patient. If your primary from the small intestine and the tumour on the liver have been removed successfully by surgery, then more very small ones appear 6 months later on an MRI. Are these from the same primary or another one, or are they too small to be seen during surgery?
So, again, just as Donal said, every patient is different, but just in general, we call the primary the small bowel, and wherever else we see lesions in the liver and the lung or in the lymph nodes, they're what we call secondaries or metastases, but they're all being generated by the original engine, the small bowel net. So if everything is taken away and it's all gone and cured, and then new lesions appear, you have to determine what those new lesions are. Are they from the net that you had? Let's say they happen within a few months or something, they are most likely from that, and we may not need further tests to determine that. If perhaps they're 2 or 3 years down the line, could there be all the other tumours that any person can get? We need certain scans to determine that. We need the test that Lisa was talking about, maybe blood tests, maybe hormone tests, maybe some of those special scans, the octreotide scans, gallium PETs, or ultimately a piece of tissue, a biopsy. So it depends on the individual circumstance, but presumably they are metastases, but we can't presume that, and sometimes we have to work it up more.
I'm Tony, and I'm on this journey for in excess of 10 years, although I probably had an undiagnosed journey before that for at least another 10 or perhaps even 20 years. I'd like to start by complimenting the team for being here today and for sharing all their expertise and knowledge with us. And compliment them also on the wonderful progress that's been made in St. Vincent's in bringing PRRT to Ireland. I think that's absolutely phenomenal. Thanks to Mary and her husband Owen in recent times, I've been reading about a new treatment coming down the line in the United States called Histotripsy, or Histotripsy. It's a high-intensity ultrasound treatment for NETs on the liver in particular. And it's now FDA approved in Chicago, and I understand there's also a clinical trial ongoing in Leeds in the UK. I believe that this is a wonderful potential, and I wonder if any of the team would have any comment to offer on it as a potential future treatment. Thank you.
I suppose I could start on that and see if anyone has any other specific thoughts, but I think on some of my slides I might have mentioned there are liver-directed therapies, so obviously surgery is the obvious thing. You remove the tumours, just like the gentleman mentioned. There are other tools we have to burn tumours or starve them of their blood supply, so embolization cuts off the blood supply, the nutrients. There's ablative techniques where you burn them. They can be done by microwave, radio frequency. You can even give chemotherapy directly into the liver, hepatic arterial infusion chemotherapy. So there's a number of different mechanisms to treat loco-regionally. And as we said, that's particularly for people maybe with liver-dominant disease, liver-only disease, or maybe a lot of hormones because of that from the liver. So it's fantastic. All of these new techniques are improving and getting better and more defined. And I guess that's one of those. Any other comments?
And I'd just like to comment about this is in clinical trial in Europe. I suppose the important thing of this group in general, the people who love NETs as we've described, is that we're aware of these clinical trials and that we, as much as possible, can look to put our patients into these trials where appropriate. I think there are a lot of treatments out there over the years that have looked like they were going to be the next best thing, but obviously they have to be trialed and assessed. So I think, again, moving forward and continuing our involvement in clinical trials is so very important.
And then there's a reason that we come to meetings like this, because I've never heard of that. So I will go away and I will read up about that, and we will be, that's the bi-directional relationship that goes on. I saw a lady this week in clinic who had juvenile arthritis back in the 70s, right? When she was age 7, before there was monoclonal antibody treatment. So she's had every joint in her body replaced, including her knuckles, and she's in a wheelchair. We don't see that anymore now, because monoclonal antibody therapy came along in about, was it the 90s, maybe 80s? 90s. So you just won't see that anymore. So the advances that are happening all the time are incredible. This lady has all her joints, but her shoulder was replaced, and then they had to take her shoulder out. And her party piece, she's a fantastic person, is she can throw her arm behind her back, right? And she did it, right? And I had a transition year student with me, a 15-year-old boy. She threw her arm behind her back. I kind of almost gagged. And the 15-year-old boy went, "That's cool." Right? As a 15-year-old boy will, right? So the newest technology that's coming is nanobody technology. So one of the things with monoclonal antibodies is they're big, so they don't get everywhere. They don't reach everywhere. Nanobodies are 10% of the size of monoclonal antibodies, so they get further. So the monoclonal antibody therapy that has revolutionized psoriasis, arthritis, Crohn's disease, is going to get like 90% better with further reach in the next 20 years. So all these advances are incredible. They're very expensive. We're very lucky we live in the developed world with a health system that will support them. But, it's about, we talk in NETs all the time about the right treatment at the right time and not going too early with the treatment, so that when you get the treatment when you need it, and then you're still, if you like, in the game 5 years down the line for whatever it is that's going to be used and there for you 5 years down the line.
From the patient's point of view, this procedure seems to be totally non-invasive, and from the patient's point of view, that's a huge bonus. And the results so far have been extremely positive. So, thank you.
On that topic, and Hussein, you mentioned clinical trials coming up in St. Vincent's and that. So are we as Irish patients going to have greater access, easier access to clinical trials now than there has been?
Thanks, Mark. Yeah, as I mentioned, this is our next focus really, and it is a requirement of being a centre of excellence to give the access to the Irish to Irish patient to be part of clinical trials. Mark Doherty has great experience coming from Toronto, and he was involved in a lot of clinical trials over there. We have 2 clinical trials in the setup process now, and we are looking into more. And this definitely will be the focus in the next coming years.
Good morning. My name is Aidan Hennessy. I've been on this journey 30 years now, and I've been on sandostatin a very long time. And over the last number of years, every maybe 2 years or so, the sandostatin seems to stop working. I become quite symptomatic. I go off it for 4 months, 5 months, and then it's like a miracle drug again. And I'm just wondering, are you aware of that in any other patients, or am I just out my own?
No. So the statement that if you have something rare, go to where rare is common. I remember seeing that at some presentation last year, and I've used that line a few times since, because NETs are rare, and then within NETs, everybody is different. So that's not a very atypical story, that it would kind of, the effect would wear off, and then you come off it, and then it would be effective again. But it's...
We do see that, or we do hear that story with other conditions and other medications, but some of the other conditions that we use the similar drugs for will be pituitary disorders. And sometimes we can find that patients are doing very, very well on the drug, and that then for whatever reason their blood tests go off a little bit, and maybe they're not tolerating the drug very well. And we take them off the drug sometimes to reassess where they're going. And as you say, when we put them back on it, because we would retrial it before we'd stop it completely, sometimes we do find that patients do well second time around. But that's using the drug in another context. But again, you're talking about your experience, which is in an unusual condition with an unusual response, but not unseen in other conditions.
Or sometimes the drug itself can cause symptoms that could masquerade the symptoms of the cancer. So if you had Carcinoid Syndrome and had diarrhea, and you get somatostatin analogues and that clears that up, if you're on it for long enough, sometimes it can cause another type of deficiency of enzymes that cause another type of diarrhea, steatorrhea, and that could be actually from the drug. You take away the drug for a while, you get that homeostasis, and then you're back to the cancer-related issues, and then the drug can be helpful for that again. So sometimes other factors are at play.
Hello. This is my first time here, and I suppose I've just found it very encouraging and reassuring. So I really wanted to thank the committee and the clinicians for such a good event and for all the hard work that you are doing. I had a Pheochromocytoma, which is always hard to remember how to say, a few years ago, and it was removed, and I'm being monitored every year. But that is over in London, where I live. I'm hoping to move home fairly soon, and I suppose my question is, out of the different centres that have been mentioned, is there one in particular that I should be looking to sort of engage with for my sort of ongoing care? And I suppose another kind of question is more about research, because it's such a strange and rare tumour. I've had lots of health problems since it's been removed, and the kind of feedback I've got was it might be related, but we don't know because we don't have the data. So I suppose I just love to be involved, if I could, in trying to help with that in any way, and again, how to sort of get involved in that.
So I'm going to just say that, like we said, with absolute respect, we really appreciate and love NETs and looking after patients with NETs. I have to say that we also adore, some of us, particularly the endocrinologists, adore looking after patients with pheochromocytomas. I will tell you, I showed you the picture of Galway today, and I would suggest you move to Galway.
Sounds good.
I would suggest that Galway is the best in general at everything, but of course I'm biased. But I'm sure any of the centres, there are a number of centres in the country that have a high throughput of pheochromocytomas. Galway is one of those centres, and we would be more than delighted to look after you. But I know there are other expertise in the country. Very involved with research internationally on pheochromocytomas. One of the leading lights in this area was mentored by us in Galway and is now working in Cambridge. Ruth Casey, she came from our unit in Galway. The first audit I gave her to do was to look at the genetics of our patients with pheochromocytoma, and she's become a world expert. So, Vincent's, Cork, Galway, absolutely a pleasure to look after you when you decide to come home.
Thank you.
So, I fully echo, Marcia's comments. The body is amazing, right? And if you have had an illness in the past, so I'm going to say, for example, you've had a stroke that you've recovered from, and then 3 years later, you get pneumonia, you might have the same symptoms of the stroke back because your body is stressed and it remembers that event and it reproduces that event. It's called a stroke mimic. And so if you have had symptoms from a condition and then that condition is treated and, let's say, inverted commas, cured, and you get an illness later, you might have the symptoms back because your body remembers those symptoms. And it's not that the disease is back, it's just your body is recapitulating that event, because the body at some levels is a kind of simple thing, and then at loads of levels it's incredibly complicated in a beautiful way.
Sorry, just to say, I think it's worth saying that for those in the room that haven't heard of pheochromocytoma, like we in NETs, we know we're rare in the cancer community, but pheochromocytoma and paraganglioma are very rare within our community. So, you know, good luck in all your journeys. Another question?
Hi, just I suppose a couple of comments and questions. So the first one comment, it wasn't something I had planned to say, but just with the other patients that came up in relation to different physicians at different centres or whatever. So just an experience I have had twice. I had PRRT treatment back in 21 in Uppsala, and I had symptoms afterwards, and I was advised to go to the local A&E, which I did. So I just explained to them, I'm just back from Sweden after the PRRT treatment, and the question that was asked, is that a therapeutic treatment? It's just maybe the A&E doctors may need to be more knowledgeable of NETs, because that particular lady, she wasn't aware of it at all, you know, and just trying to explain to her what it was. And just on another occasion, admitted, because I got sick, it was a gallbladder issue, and admitted to a different hospital, and because I just happened to be away at the time. And like I said in A&E that I was a NETs patient, and again, kind of they didn't understand it, you know what I mean? It, you know, so I just think it'd be a good idea maybe that they're more knowledgeable at A&E, that they understand that, and definitely for the carcinoid crisis or whatever, so that they'd be in tune more maybe to what's going on.
Hi, hello. I have experience, I'm working in A&E for 3 years here in Vincent's. And then when we triaging patients coming into us, for example, like pain and everything, and then most of the patients are telling us which team are you looking after? For example, like you're looking after which doctor? For example, they said, oh, I'm from neuroendocrine, I'm from gastro. So what we're doing sometimes, we alert the gastro team, we alert the neuroendocrine team, and then we spoke to them that you have a patient in here that needs your medical attentions or everything. And that's the time the neuroendocrine or the team come down and see the patients. That's what you call direct admission or direct contact. And the second thing is I like to implement also education. Education to all nurses. That's why we never stop educating some nurses in the hospital that neuroendocrine exists. And then also we have a team in here that looking after neuroendocrine patients who is having PRRT, and then they have radiation as well. So we have to be precaution when it comes to radiation. So that's why education is number one. I know you're right about it, that they should be educated. So that's why we're continuing doing that. Until now, it's in the process continuing, and we will never stop until everyone will know about neuroendocrine. And the third thing is communication. So that's why we have to communicate to them. Some of the patients, we give them a yellow card. A yellow card shows to them that they are neuroendocrine, they have radiation. So it's easy for the nurses to know and what to implement at this time, and then be cautious of what they have to do with this patient and to give the optimum standard of care. That's all we want to do. And then you're right. Education is the key and communication is the tool. Thank you.
And just the other in relation to the clinical trials, like how far off do we think those may be? And with the alpha emitter PRRT, like I think that's not expected to be approved maybe for 5 years. It's just I listened into the ENET webinar during the week, and that was the message that was given. So even if clinical trials aren't available here, should a person, like if they're at that stage where they potentially need to go on to a different treatment that's not here in the country, like can we avail of clinical trials in different countries? Like if it was in the UK or wherever it may be, you know, are we considered for that? Or because it's not in the country, can we just not have it if we were suitable for that treatment?
Before you answer that, can I just say to people that like what you're referring to, the alpha PRRT versions. So like we're delighted to have lutetium as a treatment in PRRT, but there are trials going on these alpha emitters, which are more powerful, less distance travel, so they don't cause as much damage across the body. So they are in trials. And so just so people know that these things are potentially coming down the track, but they are many, many years away.
Sorry. I'll just make one comment. So first of all, there's a really good network for clinical trials in Ireland called Cancer Trials Ireland. So each institution may be doing certain trials of their own, but they kind of often or usually for cancer join into this umbrella group, Cancer Trials Ireland. And it's a really almost unique compared to maybe other specialties like cardiology or renal, where it's a multidisciplinary group. The surgeons, there's radiation oncology. They meet every couple of months to discuss the trials that are available to try and bring in from Germany or England. Is this applicable to Ireland? Will we have enough patients? So just to say, there's a brilliant established network, multidisciplinary network for trials in Ireland that tries to bring those trials in from abroad. Patients can get trials elsewhere. I would say for other cancers that I treat, it can be challenging to get them in the UK. There's Brexit. They will obviously prioritise their own nationality, so that can be a challenge. But again, just like we said, NETs are heterogeneous. Every trial is different. Every indication is different. And because it is a rare tumour, sometimes they're looking for patients to build up those numbers. So I think you look at the trial, you look at the country, whatever it is, and you ask those questions. They're often contactable, you know, the units themselves, and then talk to your treating physician and maybe get help to get on that trial. So I would say anything is possible.
I think Greg covered most of the answer I wanted to say. So alpha PRRT is exciting. We don't have any plan to set up a clinical trial at the moment in Ireland with alpha PRRT, but we are looking into what would be the centres that we could send Irish patient to be involved in such clinical trials.
And again, I had never heard of it.
There's, if anybody wants to sort of get a list of what clinical trials are out there, on the INCA website, which is incaalliance.org, there's a really easy to use search tool, which sort of eliminates a lot of the medical jargon and it tries to simplify it. So you could use that. Now there's not much around here happening, but it is a good tool just to find out what's going on in the area. and it lists all the trials and those that are open and where they are and how many patients are signed up and so forth. So it's interesting just to browse it. So it's on incaalliance.org under clinical trials. Next question? Oh, do you want to say something?
And there is research going on in this space. So myself and Hussein are doing a project on NETs, and some people here will have contributed to that project, and some of you will have signed consent forms. You know, maybe next year we'll do an update on the research activity, because asking questions all the time, thinking about it, everyone brings different things to the table. That's why it's a multidisciplinary team. I don't mind, so I haven't heard of your treatment or this alpha treatment. That's not my bit of this job. We all have different bits in that multidisciplinary team functioning. But I think next year we should update on the research activity that's going on.
Again, on a similar topic. So the webinar that happened last week, the NETs Inca webinar, there was a discussion about research that's going on, and there was a call from the physicians there to patients to be positive about releasing your information, about any samples that are requested. So patients can get involved in research just by agreeing to let their information be used, agreeing to let the samples be used, because the physicians, the researchers, need access to those materials to develop new medicines. So they did put that out and just requesting. So if, you know, here in this room, if that comes up, be positive or think positively, as opposed to saying, well, I don't want my information shared. It really helps to advance research by sharing that.
Hi, my question is more in relation to long-term pain relief for NETs patients. I have small NETs in my liver, and I'm year 3 on taking OxyContin. And I was wondering, is there any alternative medicine that I could be using other than something that's probably damaging my liver further on a long-term basis?
Who wants to take that?
Again, I'd probably echo what Donal says. We all have our little specialties in what we know about, and then we have to acknowledge, like the person in casualty, what we don't know about, but we should at least know where to go for that information or how to signpost people. So when it comes to those kind of questions, I know the people to ask in my own institution. So, for example, there's pain teams, which are often with anesthetics doctors, and they can do injections, they can do blocks, they can do all sorts of great things. Some people don't like this word, but there's the palliative care teams, the symptom control teams. We often use that. It's not palliative care, end of life. It's about controlling the symptoms. And like many of our talks, it's about quality of life. It's about living with this. It's whether you're cured or not cured, it's about being well. And it's to avail of all of those services. And that's where Fionnuala and Barbara from the Irish Cancer Society can signpost people, or your physician. So what I would say is, if you have a treating physician, you ask them, where can I go for this? And if they don't know, they should be able to find out, talk to anyone. And so we have pain teams, we have symptom control teams in all of the institutions. And I would say that's the best way to go, because again, every individual case is different. Do we treat the cancer to help the pain? Do we use all the different modalities, opioids, other supportive medicines? Lots of options, and it's to go down that route of trying to get the answers for yourself.
And can I just add to that sometimes, more than any of what we do, as I said, I'm an endocrinologist. There are lots of endocrinologists in the country, but I love NETs and paragangliomas. There are people that manage pain and people who work in palliative care who have a special interest in special areas. So I suppose if you do look to get your pain controlled and it's not, and so, ask the question, is there anybody in the country that has a particular area interest in your type of pain, then I think that's the questions that your treating doctor should be asking and you should be asking. Okay.
Yes, thank you.
I just think my daughter and I are an interesting combination because we are both suffering from NETs. And I maintain that I started when I was about 40, which is over 30 years ago. I mean, when I look back now, the symptoms that I suffered then in the early stages, they were never diagnosed. I was comparing them with symptoms that my mother had. And of course, in those days, nobody recognized something like this. So I reckon that there is something in our DNA that leaves us prone to this type of thing. And why did my so-called carcinoid tumours do very little to start with, or they'd be a bit annoying and then they'd ease up and then get annoying again. But about 5 years ago, they turned very, very nasty. And that's when the flushing took place. And of course, I thought it was high blood pressure and all kinds of things. But just let's say it was diagnosed anyway as NETs. And then the next thing is my daughter had NETs diagnosed. There has to be something. Is there any area of study or anybody willing to investigate this? It was a bowel tumour that we started with, both of us. Yeah, and then it went to our liver.
Thanks. Very important question. So most of neuroendocrine tumors, they just happen what we call sporadically. There is no genetic component to them, but there is the rare group where there is some genetic component, and we do have criteria to screen. So we don't send everyone for genetic test, but when we see in the clinic, there are a couple of questions we ask, and obviously if there is, the first one would be if there are any other family member affected or other things that might point to a genetic syndrome. There are a lot, to answer your question, there are a lot of research with other, for example, European group, they did for family member, even if there are 2 family members affected with NET, to date, there are very few genes identified that could contribute to NET. There might be more coming in the future. The next a few years, we might have a gene that we know that might cause NET, and then there is what we have so far is limited, but we'll wait for more answers in the future. Yeah.
So the incidence of this is like 1 in 250,000. Okay, so it's either like infinitesimally small chance that this is by chance. It is absolutely 100% likely, or 99.9% likely that it's genetic. And we have patients and we have families. One family I'm thinking of now at the moment where they had recurrent low blood sugars, and no genetic cause could be identified. And then the samples were in Exeter for about 20 years, and they kept screening every time they discovered a new gene. And last year they identified the genetic cause of it. So for family clusters like this, we will usually take samples and send it to wherever it is looking for genetic causes, and it'll eventually turn up. Yeah. Yeah. And that's fine, but in 20 years' time, they will be saying, oh, there it is.
And I'm just going to add to that as well. Again, one of the reasons I became an endocrinologist was one of the conditions I thought was really interesting was Pheochromocytoma. So when we were learning about it, we were told that 10% might happen on both sides of your adrenal glands, 10% might behave badly, and 10% would be genetic. We now know within a short period of time that over 40% have a genetic predisposition. I went into endocrinology because I thought this is an easy specialty. I can manage with 10%. The whole thing has revolutionized. So I would say to you that it's very likely you do have a connection, and that connection is most likely to be found. On Friday morning, I had the pleasure of meeting a family with 8 family members for a condition that's completely different, where we had done some testing on this family because the story was very, very interesting. And we had come up with a new gene that had never previously been described before in a condition completely separate. So it's not going to help you, but it helps this family. And, these exciting things are happening every day. So I think in a number of years, you'll experience that too, hopefully.
And when I was training in London, like this has been going on for decades, if there was an interesting family with a condition and one of the family members died, it was great. We'd go to the funeral and we'd take bloods from all the family. Or if there was a wedding, we'd get invited to the wedding. Now, you couldn't do this now because of ethics and consent and all, GDPR, but it was an opportunity. And you would go and you'd collect the bloods and, and eventually the genetic cause, this was, what was it? It was an MEN2B. It was one of our, Marcia, myself and Hussein are into the multiple endocrine kind of neoplasias. So it was that kind of cohort. So genetic testing has been going on for decades, and the sensitivity and the specificity is just getting better and better and better.
We now know he doesn't get massages and he went to funerals collecting blood. I just want that noted, please.
Next question.
My name's David. I'm a new patient at my first time here, and it's great to hear people with it for over 20 years because it gives you great hope when you hear that. I've two questions. One is to thank you guys for keeping me alive up on stage. I think that's a big thing from everybody in the room. You do keep us alive, and I appreciate it. Notwithstanding, I was going to have a go about communication and coordination. Communication is just when you're a newbie to this and you get a phone call and you said, well, you could have liver cancer, and when you're not a medic, you sit back in a bit of shock and you're just wondering, like, where's my life going? Or you get a call down the road, maybe you got to get some chemo. You might be getting it, I don't know, maybe the next time. Like, I think a lot of us are a lot older. There's a new world of communication through virtual, and that's fine, and phone. I accept you guys are so busy, but when you get a shock like that, it hits your mental illness, and how do we handle this? And I'm not being critical, I'm just saying, is there a better way we can maybe communicate? Secondly is coordination. I know our IT systems are pretty horrific in a lot of the medical, but if you're dealing with 4 consultants in different areas and you get a call from outside of the NETs group and you're asked for bloods, you're wondering where the next vampire is going to come from because there's blood being given everywhere. And you go to a cardiologist, they want it, and they say, well, my job is to keep your heart going, and then the others are to keep your vision going, your eyes going, or whatever. And there just doesn't seem to be a coordination. And once again, that really starts hitting on your mental health. So I'm just not being critical, I'm just saying, is there any way it can be done any way better? Thank you.
I suppose what you talk of, it happens in every walk of medicine, and it's partly, I think, because we try to do more sometimes than we have ability to do. I think that it's what we do as clinicians is, to some degree, it's important, but it's probably no more important than the people who work with us, who make appointments, who schedule things, who set up visits to the clinic. We will, I think, all put our hands up and say we could do this job better. We could do, and we could make your experience better. We could ask for more staff. We won't get more staff in a lot of situations, but I suppose, I learn from situations like you're describing now, and hopefully then, I'll try to make things better. But unfortunately, unfortunately for many people, they will have bad experiences at times like you describe. I was really encouraged to hear about your buddy system. I imagine it must be fantastic to meet with somebody who has gone through your journey and is 30 years down the line of your journey. But again, I can only apologise, and I can only say that we will try and learn from what you're talking of, and try and make things better, and ask for more resources.
Yeah, thanks a million for making that comment, because that's the real world. And I've sat on that side. I've had family members with cancer, and I've witnessed everything you have said. And sometimes I think, we are treating the cancer. I've said we're trying to treat the patient in sometimes tough environments, but it's only until you've experienced that and maybe sat on that side and had the cancer or have had a family member that you can really appreciate just how challenging that is. And the small things, the blood tests or the scans that would be small in our thought process are huge for you. So 100% empathize with that. And just on one of my slides, I mentioned we don't have a cancer centre in Galway. I work in, as I said, even worse conditions than Marcia, despite what she says. And we see people, anyone who's gone through the oncology day ward in Galway, it's horrific. It's absolutely horrific. And we're trying to change that. And I feel so sorry for the interactions we have with our patients, who are amazing. The staff are incredible, particularly the nursing staff that work in these conditions. And then I go down to, there's a beautiful new radiation building in Galway. It's spectacular. And just that baseball film, Build It and They Will Come. And I walk down there to do a consult, and it's spacious and it's white and it's modern. And the whole interaction with you, the patient, is totally different because of that environment. It's quiet, it's peaceful, we have time. And I'm so envious, and we all want a better environment. And I 100% agree with everything you've said, because I'm on this side, but I've been on that side too.
And I feel sorry for that, but I apologize for it. But I know how you feel. That's why I spoke to Barbara earlier, the Irish Cancer Society. If you need some help or something to talk about, they have their website. You can give your experiences to them, and then all your questions will be answered with them, answered by them. And it's really, really good. Some of the patients, according to her, that it's really good thing that they have this, to reach out to them, and then we are here for you, to stand beside you.
Sorry, I just want to say one thing, David, thanks for that. Sometimes also, I think at the start of your journey I know you're in Vincent's, it feels very disembobulated. Maybe you're going from one physician to another, from one area of the hospital, from the private hospital sometimes to the public hospital, and because we don't have electronic sort of record of the patients, we still have the old-fashioned paper, when lots of times kind of communication, etc., could be better. I would hope that as you go on with us, that things would settle down and feel more organised, and as I say, when it's very new as well, you're probably getting your bloods done every department, etc., etc. So hopefully, as you go along, it might seem hopefully a little better.
And communication is absolutely key, completely critical. So I remember a number of years ago, there was a patient who was an inpatient and had a biopsy that confirmed a neuroendocrine tumour. I went, explained that this was a neuroendocrine tumour, and about a half an hour later, my brother works in the hospital as well, and he said, you need to go back to that person. He's ringing his family saying he's delighted he doesn't have cancer. It's a tumour. And we forget that. We say neuroendocrine tumour and we immediately think the person will understand what we're saying, but actually not so. So how you explain things is so important.
Just four of you apologise. No one needs to apologise to anybody. To me, no one apologise. What you're doing, I'll say again, you're keeping us alive, and thank you.
I had the misfortune of being a patient that was diagnosed in Donegal. Lovely part of the country, no more than you love in Galway, I love Donegal. Needless to say, the infrastructure is not there. Is there not a way that ye wonderful people and the people that support you in your jobs can develop a policy that is circulated to each and every general hospital that has dealt with each and every one of us initially, before we were fortunate enough to get to use, that when that neuroendocrine NETs is diagnosed, that we are give the information that you guys exist. Sorry, I have swimming classes. That my journey would have been less stressful on us with a young family. I had to seek yous out. I had to seek Cassan out. Nobody in Letterkenny told me that you people existed. I was never told there was a centre of excellence in Ireland. I eventually got so pissed off with them, excuse my language, that he started researching it, and we went to our GP then and asked to be sent to Vincent's. To save the people coming behind us, we're halfway through our journey here. Some of us are at the end, some of us at the beginning, some of us in the middle. But for the next Emma with 3 kids, the next granny, the next granda, the next person going through the doors with the symptoms that get said, look, you've got neuroendocrine cancer. There's a group of people that love this disease and want to meet you. That's all you need to do. Get that information to the A&Es in Letterkenny, in Kerry, in Galway, and everywhere. It's going to make our journey that we don't hate the health system that we're inhibited in. You do you understand what I'm saying? That we get to use quicker, and our pathway is less stressful than what it has to be. Okay? It makes it easier.
So I'm going to start by apologising again, because one of the things that I showed you the map earlier, so one of our areas to cover from an endocrine point of view, and you may not have been referred on to endocrinology, but one of our areas covers Letterkenny down to wherever that yellow piece ends, and then we add on the pink. But what I would say to you is more and more people are aware, because of this meeting, because of the people who are interested, being in a position to meet and talk about it, it's becoming more known who the people who are interested in the condition and who are able to help. I think we talked this morning, again, we had a meeting last night where we met with some of our colleagues in the north, where anybody who gets a diagnosis pathologically of a neuroendocrine tumour, it immediately generates a signal that allows that person to be discussed through the MDT. That's it.
The onus is not on the person that is stressed. The day I was told I had a neuroendocrine cancer, I was one of those people that heard NETs. I'm a nurse. I never picked up. I went 13 miles from the hospital and rang the consultant back and said, hold on here, did you just tell me I have bowel cancer? And he said, yeah, am I left too quick to discuss it? I was elated, I was confused. But it took 18 months to get to a specialist in the field. I think Ireland we're better than that.
Absolutely. But I think that'll improve. And to give you some degree of hope, one of the other things I look after is thyroid cancer. And if a patient with thyroid cancer in that yellow area, or indeed in the pink area, is identified, then then it comes through our MDT, and I know about it, and they come to be followed in my clinic. So that wasn't there 10 years ago. It's there now, but I would suspect in the not too distant future it will improve. That this pathway will improve. The pathway where you'll get to meet the people who are interested fast will happen.
I just want to say that when we realised you were there, it was like a burden was lifted of us, that a light switch, we didn't have to do the work. I was having it hard enough trying to be a parent while sick, and he was with a sick wife and also being a parent. It was when we got to Vincent's, we went, we're not the only ones here. that could be just so much easier if that wee bit was done for the patient rather than them having to source their own consultants, as in our case. Okay, thank you.
I think what Marcy said there, it is becoming more known about, but there has to be some sort of mandatory referral, a trigger that happens. And I know it's not happening at the moment, as you experienced.
We should have an electronic patient record already. It's mortifying as a country that we don't. We get inspected internationally, and we're accredited as a centre of excellence, and they're still looking at you, and it's paper, charts. When we have an electronic patient record, those triggers will happen automatically. So it'll happen.
But I think the NCCP has a role to play here in producing a rare disease policy, which they don't have at the moment. Am I right?
So the recent budget did fund rare disease for the first time ever. So there is a rare disease strategy, there is a rare disease group, and it is now funded for the first time with a view to building up an approach. At the moment, it's around lung and bone mainly, but it will grow.
Yeah. But we need that policy out there to be the trigger that wherever in the country that this person is diagnosed, that they get to the experts. That has to happen, and is happening, but it's slow to do.
Do you know how I tell you Galway is better than anywhere else? We have an electric patient. We have an electronic patient record for the last couple of years, and it's revolutionised how we manage patients. It's not much good until the rest of the country is linked in, but it's coming. It's coming, and it's coming, and it will help.
And everybody wants to transfer their care to Galway.
Hi, I just want to speak in relation to electronic records. I attend Tala Hospital for my NETs, and I get well treated and well looked after there, and they liaise with all the other patients, so I'm very happy from that point of view. But one of the days, myself and my husband were talking to one of the doctors there, and he was from Brazil. And of course, the technology wasn't great, the computer wasn't behaving itself for him. So he began to tell us, in Brazil, and we said, okay. And he said, in Brazil, if I'm in Sao Paulo and somebody's in Rio de Janeiro, or they're a patient of Rio de Janeiro, and so and they've come into me in Sao Paulo, I can look electronically at their files. That apparently, like, your RSI number or your PRRT number, they get a number at birth and it seems to attach to a file. And it's all, it's obviously password protected and stuff like that, but it seemed to be so normal, and, well, why shouldn't it happen? So that was just an experience of a conversation. In Brazil, they do it better.
Yeah, so I suppose just to echo what we've all been saying, we've all identified as the biggest issue in any accreditation processes that we are so deficient in every single hospital, in every single specialty, I'm sure. The NCCP are rolling out this system called NSYS, which is a prescribing tool at the moment. So potentially, as I said, I can see what's prescribed in Galway, but what's prescribed in Letterkenny. So that's rolling out. The next phase of that is we're running a survivorship program for colorectal cancer, and the template for how that should happen is on NSYS. And again, that has that functionality and other people can see it. And ultimately that will expand to have other roles. It won't encompass everything. It won't talk to maybe the cardiology system or the endocrinology. It won't be the same system, but they should be able to talk to each other, and that's the goal. So we are at the infancy of it. It has absolutely been recognised as the major deficiency, but hopefully and slowly is going to get there.
Just to say that, within the HSE Intelligence Unit, and I'll repeat that, the HSE Intelligence Unit, has progressed to the point that the what's our number? Our PPS. The PPS is going to be the number that will underpin our electronic patient record. The National Children's Hospital is going to be EPR, electronic patient record, when it opens, hopefully next year, and that is going to be the first hospital that's ever amalgamated 3 hospitals into one hospital in a 24-hour period and gone electronic in the same 24-hour period. Like I just think the concept, the scale of things for that move is going to be just massive. But you know, and then James's has an electronic patient record. The Central Mental Hospital. So there are, but they all need to be the same, and they need to be able to be in Sao Paulo and Rio and looking at what's gone on.
So Catherine has joined us from the Treatment Abroad section in the HSE, and Catherine's been at all our meetings that year after year. So we're less and less questions about treatment abroad, because like PRRT now is in Dublin, but it's still happening and still required. So Catherine, do you want to just tell us what's going on there?
So, just to pick up on a few things that you've been discussing here today. So in relation to electronic records, the European Union is also working on them. And soon, in the coming years, in the same way you've got a wallet on your phone, you will have a wallet which contains your European health record. Things like your European health insurance card, your vaccination status, all that will be in your wallet, being worked on and coordinated at Commission level. You were asking about clinical trials. Just before any of you think that it is that simple to enter a clinical trial, while yes, you may be accepted onto a clinical trial in another country, remember it is the hospital or the pharmaceutical company that runs the trial, pays for you, not the Irish government. So before everybody rushes off to enter trials in another country, remember there's a cost implication. And while they may be willing to pay for your tests and everything else while you participate, they won't cover your travel or all the other ancillary costs that will be associated with it. Okay.
And treatment abroad for PRRT, even though if you can't get in Dublin, it's still happening.
So yeah, PRRT is still happening in Uppsala. We still have a number of patients travelling. We made a commitment that we will continue to support that, and we will. We are supporting PRRT for NETs patients. PRRT for other conditions like prostate cancer, that won't happen in the foreseeable future. Okay, those patients will continue to have the treatments that are available to them in Ireland. Okay.
Thanks. Any more questions? We'll be finishing up shortly. Hold on. Oh, you've got a microphone. Wait till you get a microphone. Wait. So I think there's one there, and then we go to you.
Sorry, yeah, if you do get to the stage where you need PRRT, how do you decide who gets it in Dublin or who goes on the holidays to Uppsala? Or even London? I do believe London is another option.
Your consultant decides.
On what basis? Is there criteria, specific criteria, or is it the luck of the draw?
So at the moment we are welcoming everyone to come and get the treatment in Dublin now and try to accommodate everyone in Dublin.
Some people are going abroad, and as you mentioned, London is one option, Uppsala is another option. Most of us here have been to Uppsala to do a kind of a course they run. It's not really a holiday. It's just Uppsala. And then I guess because if there was a timeliness, say, but the goal is to accommodate everybody who needs PRRT in Ireland. But we always said, as Hussein was standing the service up, there was going to be a transition period where there'd be some people needing to get it abroad just on a timing basis.
Just one thing there. Trying to get people to sign up to giving their PPS number to a lot of organisations. I don't want my number, my PPS number going to this one or that one, because they might know too much about me. But what are your chances of getting that information then about me, will say, if I don't sign up, around in different hospitals? And the other thing is, I had a pacemaker fitted recently, and I've joined with HRI, Heart Rhythm Ireland, and I'm led to believe that all the hospitals, a lot of them have signed up, so that if I go into any hospital anywhere, they have my information with the people that have signed up. So maybe with the, hospitals not knowing what some people are on, like the lady here behind me was waiting 10 hours. Maybe if she had a card that marked on it that this is urgent and signed by the NETs people, maybe she would have got her service a lot quicker.
So I think overall, if there's a legislative push that our PPS number becomes our unique identifier, then that ship has sailed, if you like, and I don't think it may not even happen during my career, the way things are going, but I'm hoping it'll happen over the next 10 years. And I guess you'll always have the option to opt out, but then you will be taking the consequences of maybe not having health access, people having access to your health history. And I think most people will opt in. It's like vaccination. It's 95% of people will go with it, and a small percentage won't and will take the risk of not being vaccinated. But that ship has sailed in terms of Big Brother watching everything we do, tracking our music choices and our television preferences.
Hi, yeah, as one of only 2 departments in the Health Service Executive that's allowed ask for your PPS number, I fully agree with you, and we absolutely respect your privacy and confidentiality of your PPS number. Recently I got my breast check letter, but on that there is a unique identifier for you within the health service, so that has already started. They're not using PPS numbers, they're using a unique identifier, a unique number to every person. So you're absolutely right, your PPS number should not be given, and it should not be accessed by anyone unless they have specific permission to do so.
Can I add to that, though, that's about the health records, electronic health records. But when your data is being there used in research and in hospital for research purposes, usually that's highly anonymized, and there's very strict guidelines about how they can use that data and not to be identified. So it's very, very strongly controlled from a research perspective. So that call to try and share. You're sharing the information, but you're not sharing who you are. So, it really would be helpful to release your information. But it's not about you personally. It's not about no identifying thing. The electronic health record is a different thing where you have to be unique. So that is a different thing. And on the the card or whatever, to say that you have a problem. Like we had that discussion last year, and it was really emphasize that, yes, great if you had a net card that said you had this problem, but then there's people with breast cancer and diabetes or whatever, and everybody has a card, so they all become pointless because everybody comes onto the emergency room and everybody gets triaged, and then they decide what to do. So, you know, there's no point in having a net card for that. Yes, have a card that tells, and we did this with Hussein, have something that says this is the disease and these are the problems and so forth, and then you can present that, but you can't skip the queue, you know, because everybody else that's there has a problem, has an issue, and in the ER they decide who gets seen first, and that's just the way life is in the country. Any more questions? Right.
Sorry, just a question in relation to the treatment abroad scheme. Now, I stand corrected on this. So we'll say it's for funding for treatment that's not available in the country. And it is a fantastic service, like I availed of it when I went to Uppsala in 2021. But for the clinical trials, like how is it differentiated that, okay, the therapy isn't available here, but yet it's not covered by treatment abroad to be involved in that clinical trial?
Okay, so this is where I start to get technical. EU Regulation 883/2004 sets out the rules for the treatment abroad scheme, and it is specific to proven therapies. So a country is not required to fund a therapy that isn't proven, and that's where clinical trials fall into that bracket. The danger would be that any country, any hospital, any pharmaceutical company could start a clinical trial, and next thing, countries all over Europe are being required to fund the patients attending it. So it's always the hospital or the pharmaceutical company running the trial who pays for the participants.
So if we say a treatment had regulatory approval in a different country, say it did the clinical trials, it passed, we'll just say for the FDA, for the US, it had passed the clinical trials, or I don't particularly mean the US now, or wherever. So would the treatment abroad scheme cover that then? The fact that it has been through the clinical trial, it has got approval by the regulatory body?
Okay, so again, I'm going to get kind of technical on you. If the treatment was a treatment in Europe, which is approved in one country and recognised proven treatment, like that's what the treatment abroad scheme is for, okay? There can be situations where there is a treatment in another country, but there's equally a treatment in Ireland. The treatment in the other country might be more technologically advanced and might have fewer side effects and whatever for the patient. The fact that there's a treatment available in Ireland, albeit one with more side effects and maybe not the one that not as technologically advanced, that's the one you're entitled to. The HSE is not required to fund you to go abroad under the treatment abroad scheme. Then we get into EU Directive 2011/24/EU. And that's the one you can use to access a more technologically advanced treatment, but you pay for it yourself up front, and then you're reimbursed at the cost of the treatment that you would have been provided with in Ireland. There can be exceptions where there was a justifiable medical reason, clinical reason, where a consultant can say, look, there is a particular reason why we would recommend that this patient be given a chance at a more technologically advanced one. For example, if the patient was to have their treatment here, they will lose their leg, whereas there's a treatment in another country in Europe, and it's worth giving the patient a chance at it because it might save their leg. And then if not, the leg gets amputated. And that's an actual case that I had. And those were the choices that you're faced with. Yeah, only in the European Union, so EU, EEA, Switzerland and the UK.
So, no more questions? No? Yeah?
So just two things. One was something that came up earlier when I was telling people when we were accredited in 2023, re-accredited as a Centre of Excellence, 5 inspectors came, including somebody from Uppsala, and we gave them a present of Tommie's book, Never Better. And the people from Uppsala looked at it and said, but he is well. Why would it be so negative? So they read it as never better, when it was actually never better. And it was just really strange to see the reaction to the book, you know. Second thing, my day job is obesity, as some of you will know. And I did a TED talk a few weeks ago. Some of you will not have heard of TED Talks, but they're a thing. And it was uploaded onto the TED website this week. Mark is going to email a link to the TED Talk. So it gets demoted or dropped if you don't get enough views. And I was told, but it's okay, use your LinkedIn and your Instagram. Well, I don't have LinkedIn and I don't have Instagram. So I need you to click on the link, watch it, comment on it, share it. And I'm going to count the number of people in this room. And if there aren't that number of additional views by tonight and I'm dropped, then I won't be here next year.
In my mind, that's akin to stealing blood at funerals.
So we'll send that. Margaret does our newsletter, so we send it out in the newsletter, the link, and we send out an email more quickly to get that out there, and we try and get as many views as we can for it. But I encourage you, please all do that for Donal. So we're going to wrap up now. I want to thank our panel here. We are really blessed to have this kind of a forum and to have access to clinicians like this. It really doesn't happen in other disease areas. It's so uncommon. It's a brilliant forum. I think the weekend has been great, last night and today. I hope you've learned a lot. Really, really thank you for giving your time to be here and to share and answer questions. Thank you all for coming here. You know, we lost Tommie during the year, but we continue, we go forward, and we continue to try to achieve the vision that he had of a really top-class service for NET patients in Ireland, which is happening, and there's more to go, but it's definitely happening. And I look forward to seeing you all next year. So thank you very, very much. And lunch is out in the restaurant just across the corridor. So please all join us for lunch, and yourselves if you wish to do that. So thank you. Bye-bye.